My dear students, in this video, I'm going to talk about a bit on the role of ECMO in toxicology. Let us start by discussing the first case. A 28-year-old female, a doctor by profession, is brought to the emergency department 1 hour after ingesting 40 tablets of propranolol of 40 mg, which makes us 1.6 gram in a suicidal attempt. On examination, the initial vitals are seen as heart rate is 42 beats per minute. The BP is 78 by 45. The respiratory rate is 22 per minute. The saturation is 97% on room air. And the GCS is 14 by 15. The pupils are normal. There are no seizures. And the ABG shows a pH of 7.29, bicarb of 17, and lactate of 5 millimoles per liter. The ECG shows sinus bradycardia with QRS widening of duration 120 milliseconds. The bedside echo shows LV ejection fraction of 25% alongside global hypokinesia. So, how to recognize beta blocker toxicity early? Now, this patient, which I just illustrated, has ingested propranolol, which was known. But if it is not known, in that case, one has to make out the suspicion about beta blocker poisoning based upon certain features. Now, to understand those features, one has to understand the mechanism of toxicity due to beta blocker overdose. Primarily, whenever there is blockade of the beta 1 receptors, there is negative inotropic and negative chronotropic effect, for which there is fall in both the heart rate as well as the contraction. Due to the blockade of the beta 2 receptors by any non-selective beta blocker, there will be associated bronchospasm, vasoconstriction, and hypoglycemia. So those features will also manifest. Other than that, propranolol has also got membrane stabilizing and lipophilic properties, by virtue of which it blocks the sodium channels and causes CNS depressant effect. So there are certain red flags which one should not miss in an emergency in patients with suspected beta blocker poisoning. These are early severe bradycardia and hypotension, low cardiac output despite fluids, QRS widening because of sodium channel effect, and metabolic acidosis due to hypoperfusion. Now, in these patients, we will have to go for initial stabilization and conventional therapy, which is almost similar in all patients with poisoning. And this includes taking care of airway and breathing. That is, patient should be oxygenated with intact airway, followed by circulation. Now, in these poisonings with beta blockers, after giving 1 liter of fluid bolus, like in our patient, there was no improvement. And even after giving 1 milligram of IV atropine thrice, the heart rate was still 40 per minute. With dopamine infusion, there was no improvement. And with epinephrine infusion of 0.1 mics per kg per minute, when started, it only showed minimal improvement. Now, this is also important that we understand the beta blocker toxicity by looking into these aspects. Now, there are some specific antidotal measures. One, we will have to give calcium gluconate, 30 ml, 10% bolus. Number two is height or high dose insulin euglycemic therapy, in which we administer 1 units per kg of IV bolus followed by 1 units per kg per hour infusion. And because of the chances of hypoglycemia, we alongside give dextrose infusion to maintain glucose between 120 to 180. We also monitor potassium because we know that insulin drives potassium intracellularly, so there can be hypokalemia. In addition to that, we give glucagon 5 milligram IV bolus. There is transient improvement. Then we continue with an infusion of 5 milligrams per hour. And we also give lipid emulsion therapy 20%. Lipid emulsion therapy is assuming more and more importance, although it was initially started for Last, that is local anesthesia, systemic toxicities, but it has also been used successfully in calcium channel blocker, beta blocker, where it creates a lipid sink and where the unabsorbed or the poison or the drug is actually sinks or gets dissolved and it is not available to the body for its effect. So that at the dose of 1.5 ml per kg bolus, followed by 0.25 mils per kg per minute for 30 minutes. Now, in our patient, despite all these measures being taken, the BP remained still low, that is 65 to 40 millimeter of mercury. The ejection fraction was 20%, the lactate was 9, the urine output was less than 0.3 mils per kg per hour. So, can we go for ECMO in this patient? So, we will have to look for the indications of ECMO in such a patient with beta blocker toxicity. Now, after 3 hours of refractory cardiogenic shock, despite maximal catecholamines, HIAT, calcium and glucagon, lipid emulsion, the patient remained still on hypotensive and acidotic, which means that all these measures were not causing improvement. So the indications for VA ECMO would be refractory cardiogenic shock due to reversible toxin, which is in our case because the patient had presented quite early. There was no irreversible comorbidities, and the patient was young with a short downtime and good neurological potential. So how was ECMO initiated and how it was its course and outcome? So the mode chosen was VA ECMO. The cannulation was femoral vein to femoral artery. The initial flow rate was 3.5 liters per minute. The anticoagulation was with heparin bolus followed by infusion to target an ACT of 180 to 200 seconds. And post initiation, the hemodynamics, it was seen that the MAP improved to 70 millimeter mercury, the lactate begins to fall, the vasopressor tapered over 12 hours, and the HIAT continued during the ECMO. The echocardiography showed on the day 1, the ejection fraction was 20%, which increased to 40% on day 2, and finally to 55% on day 3. The lactate, which was initially 9 millimoles per liter at the beginning of ECMO, came down to 3 millimoles per liter in 24 hours. Weaning was started and ECMO flow was gradually reduced, and decannulation was possible after 72 hours of support. The patient was extubated on day 4 and was discharged from ICU on day 6. Normal ejection fraction was noted on follow-up visit, and also psychiatry referral was completed as mandatory step. Now, what was the cause of this improvement in a patient who was not responding to the standard therapy, but finally responded when the patient was shifted to ECMO? Now, if you explain the aspect wise, it becomes easy to understand. If you know the mechanism of toxicity, which was negative inotropy, negative chronotrophy, and conduction delay via the beta blockade, and propranolol also adds sodium channel and produces CNS effects. So the conventional therapy failed because of profound myocardial depression, which was not responsive to catecholamines, and the metabolic acidosis worsened the inotrophy. So why ECMO help? Because it supports circulation and oxygenation while the drug redistributes and is metabolized naturally by its normal process. The VA ECMO is advantageous because it restores perfusion, prevents multi-organ injury, buys time for HIAT and detoxification. And the outcome predictors would definitely include early initiation, reversible toxin, short CPR time if the patient has a CPR, and absence of severe hypoxic brain injury. Let us go to a second case. A 25-year-old male farmer was brought to the ED after accidental ingestion of an unknown quantity of herbicide, from the label of which it was read that it was gramoxone 24%, or in other words, which is the commercial name or a brand name for paraquat. He vomited multiple times, had burning throat pain, and had progressive shortness of breath. During initial examination in the ER, he had a heart rate of 118 beats per minute, BP was 95 by 60, respiratory rate was 28 per minute, saturation was 88% on room air, The oral ulcers and erosions were visible in his face. There was no cyanosis initially. The ABG revealed a pH of 7.31, PO2 of 70 millimeter mercury on 5 liters of oxygen, a bicarb value of 20, and lactate of 3. The chest X-ray showed mild bilateral basal haziness. The serum creatinine was 1.8. So we again have to understand that paraquat poisoning causes its effect by generating ROS or reactive oxygen species. These reactive oxygen species cause lipid peroxidation and alveolar epithelial destruction, both of which ultimately gives rise to progressive pulmonary fibrosis. Besides this, which is the main effect of paraquat, it also causes acute kidney injury. It also causes hepatic dysfunction, and in some cases, it may give rise to multi-organ failure. But we have to remember that even if oxygen is temporarily supported, the ongoing reactive oxygen species injury will lead to irreversible pulmonary fibrosis. So finally, all the lung tissue will be affected and the patient will succumb. So in initial management, we have to go for decontamination using gastric lavage with activated charcoal. If the patient is brought before 1 hour, unfortunately, our patient was not brought before 1 hour, then we have to avoid oxygen supplementation unless hypoxic, because under normal circumstances, oxygen accelerates the ROS generation, and this might further compound the nature and kind of injury which the patient is experiencing, and avoid mechanical ventilation early if it is possible. The supportive care includes IV fluids for AKI, high dose antioxidants like vitamin C, vitamin E, and NAC, cyclophosphamide plus methylprednisolone in some protocols with limited evidence, but uh, there are also differences in opinion on that. And also we have to consider hemoperfusion early, that is before 4 to 6 hours, to remove a requisite amount of paraquat. So despite therapy, the patient's oxygen requirement increases over 48 hours. And further deterioration continues after that with respiratory rate of 38, saturation of 78% on 15 liters of oxygen, PF ratio of 65, so it mounts to severe ARDS. Chest X-ray shows diffuse bilateral infiltrates. Echo shows normal LV function. The creatinine value is raised to 3.5 milligrams per deciliter. And so the patient is intubated and put on mechanical ventilation. Now, should we consider ECMO? If we look into the aspect and observe the aspect and try to link with and interpret them as per the clinical context, we will have to make this situation applicable in our setup by asking appropriate questions. Now, if you see, the type of failure is isolated respiratory failure, where VV ECMO may be temporarily useful. There is no need for VA ECMO. Cardiac function is normal, and it needs to be. So if it is normal, there is no need for VA ECMO. Toxin reversibility, there is irreversible pulmonary fibrosis due to reactive oxygen species, and in that case, which carries a poor long-term prognosis. Timing of poisoning is 3 days post-ingestion, which means that paraquat has already entered the tissues. And overall condition depicts worsening oxygenation and rising creatinine. And the interpretation is that likely progressive nature of the disease because of systemic toxicity. So the ICU team debates upon the ECMO initiation. Some were in favor of ECMO, and those who were in favor of ECMO, their points were the patient is young and having no comorbidities. This carries a potential to bridge to lung transplant and reversible acute phase if early because of small ingestion. The arguments which were going against ECMO by the other team include irreversible lung fibrosis in most paraquat cases. ECMO may worsen oxygen toxicity. Early high mortality despite ECMO is around 95%, but not a true bridge it should not be considered as a true bridge unless transplant is feasible. So since this patient presented late and developed multi-organ failure, ECMO was not initiated. Now we have to think about situation or an alternative scenario when this patient might have come early with limited ingestion. So if the patient had small ingestion, that is serum paraquat of 0.2 milligram per ml at 4 hours, the patient does not have any renal injury and patient has ARDS developing early, that is within 24 to 48 hours, then as a bridge to recovery, which is of course rare, but more common as a bridge to lung transplant in specialized centers, ECMO can be used and ECMO support may sustain oxygenation while paraquat clears and the inflammatory injury subsides. However, survival remains less than 20% even with ECMO. Hmm. As a so now in alternate scenario, if the patient had small ingestion, if the patient did not have any renal injury, or the risk of ARDS developing was not so much, so or if the risk of developing is early, that is within 24 to 48 hours, then VV ECMO should be considered as a bridge to recovery. Very rarely it should not be, or as a bridge to lung transplantation, which is more common in specialized centers. So in this case, ECMO support may sustain oxygenation while paraquat clears and inflammatory injury stabilizes. However, it is seen that survival is also less than 20% even with ECMO, and therefore a careful decision should be taken about ECMO on any such poisoning in which the chances of recovery are bleak and the patient has limited finances or would not be able to cater to the needs of this procedure. So if we look into the paraquat toxicity causes irreversible pulmonary fibrosis where ECMO is rarely beneficial unless it is used very early or as a bridge to lung transplant. VV ECMO may temporarily maintain oxygenation but does not halt disease progression. Oxygen exposure should be minimized both on and off ECMO because oxygen can accelerate the reactive oxygen species from developing. And decision for ECMO must be multidisciplinary, factoring in time, dose, and transplant feasibility. The outcome remains poor despite ECMO, and prevention and early decontamination still remain the key. There are also various other toxicities where ECMO may benefit for cardiotoxic drugs like calcium channel blockers, beta blockers, tricyclic antidepressants, anticholinergics, bupropion, chloroquine. The ECMO, the VA type of ECMO is very useful, and the outcome, if started early, is excellent. For respiratory toxins, because of paraquat, hydrocarbon, chlorine, etc., VV ECMO is the usual type which is used, and the outcome, even if initiated early, is variable. In mixed category, we have due to metformin or organophosphate compound, in which case either VA or VV ECMO can be initiated as per the case, and the outcome, if early started, is moderate. For irreversible toxins like paraquat, late paraquat, corrosives, etc., there is no benefit with ECMO has been recorded, and the outcomes, if early, has been poor. So when is ECMO not helpful? ECMO is not helpful in the late phase of paraquat poisoning because of irreversible fibrosis, which is already happens by that time. Corrosive ingestion because of multi-organ necrosis. Methanol or ethylene glycol because it is treatable with antidote plus dialysis. Heavy metals like arsenic, lead, etc. No direct cardiorespiratory collapse, and acetaminophen where ECMO is not curative but transplant is definitive. So in that case also the one has to be careful. Now, these two are articles which has been discussed at length about the conditions on which the ECMO is useful in certain poisonings and why so, and where it should not be used. That also has been highlighted in these two articles. But one thing remains to be noted in the context of these articles, that both say that in the calcium channel blocker systematic review, although survival was high, the cohort was very selected and ECMO was used only after multiple treatments failed. So that may not be actually the external validity may not be so good if we want to take this message for our patients. So my final take-home message would be ECMO acts as a temporary bypass system that maintains circulation and oxygenation while the body clears or metabolizes a toxin. When poisoning causes severe cardiac depression, unresponsive to maximal therapy, constituted by fluids, vasopressors, higher glucagon, etc., VA ECMO provides circulatory support. When poisoning leads to severe ARDS or hypoxemia despite optimal ventilation, VV ECMO is used for oxygenation as well as CO2 clearance. ECMO can be combined with other extracorporeal detox modalities when the toxin is dialysable or absorbable, and in toxic induced cardiac arrest, like following beta blockers, calcium channel blockers, chloroquine, tricyclic antidepressants, when conventional CPR fails, eCPR ECMO can sustain perfusion during prolonged resuscitation. Thank you very much.